Now I would like to ask our panelists to come forward to the stage, and it is my great pleasure to have Dr. Girdhar Gyani from India, Dr. Sameh El-Saharty from World Bank, USA, Dr. Fadi El-Jardali from American University of Beirut, Lebanon. Thank you again for being with us. As per the program, we will have brief presentation by each panelist, and the first one would be Dr. Girdhar Gyani from India. Dr. Girdhar Gyani, he is the Director General of Association of Healthcare Providers, and he is going to give us a talk about the role of medical tourism in providing health and prosperity.
Good morning. Yeah, at the outset, I am grateful to IHF for inviting me to speak on this important topic. But at the outset, when the word is used, tourism, medical tourism, I think there's a little misnomer. But when you use tourism, it is enjoyment. People go for tourism. But will we say that somebody is going somewhere to fix the denture in one country, to go for angioplasty for another country, or let us say any other procedure? No. They do not go for pleasure. They go for necessity, because that particular procedure is not available in their country, or there is a new, let us say, huge waiting line, or the cost of procedure is too high. That's why they venture into this one. So I think that's why nowadays we generally use medical value travel. Absolutely, that is the correct word in terms of describing. Now, I see medical value travel a truly not really business proposition. It is really a very big humanitarian cause, because we are providing health care to the needy people who are unable to get it done in their own countries for various reasons. I just mentioned one. So I think I would like to start that the medical value travel is a big humanitarian cause for which I think all of us sitting here must put our efforts forward in whatever way we can do it. Now, so if you really see, whenever one country wants to venture into medical value travel, the one advantage which I am seeing is that it requires top-of-the-line hospital infrastructure. Otherwise, you're not going to offer medical tourism or medical value travel. So that is the one straight focus is coming. You create facilitating organization around you, another employment opportunity. You create associated travel agencies, other tourism ventures, they come along with that. Hotels come around that particular facility. I can give you a simple example. Let us say there is in a city like Vellore in India, Christian Medical Center, CMC. Some missionary started a small clinic. There was nothing in that city. Today, there is a huge city, and the medical value travelers come from Bangladesh, from Myanmar, right from eastern side to the down south. So that is the kind of infrastructure it has created. Medical insurance company, they get the business. And of course, as far as country is concerned, you also get the foreign direct investment. Now, I will say, associated roads, telecommunication, boost to employments, increase in GNI, and of course, I must say, improving in the relationship. Because let us say Afghanistan, yesterday His Excellency Minister from Afghanistan was here. And I must tell you here, India provides bulk of the Afghanis, they come to India for most of the serious procedures. So that actually improves the relationship between the country to country. Now, this is, once you establish a center of excellence, what I call quaternary care or tertiary care hospital, automatically there is spoke and hub model. Other mushrooming small hospitals start building up. So the point of that medical value travel also in a way leads provision of community health, Because these small hospitals, they come mushroom around that bigger hospital. They actually serve the population, domestic population of the country. So that becomes one of the advantages. And we have seen that this actually improves the health outcomes of the local country. So giving a very specific example in a couple of minutes. For example, India is a country which spends very low money, 1.2% of the GDP. But somehow somebody thought in India, the corporate culture, corporatization, private healthcare, they came forward. Today they are spending more than 3.5% of GDP. So put together around 5% of investment is coming in the healthcare, which is really something which has resulted into a very big thing. For example, India has around 55,000 hospitals, small to big, out of which around 3,000 hospitals are tertiary care hospitals. Out of which, let me tell you, about 500 hospitals are those hospitals which claim to be the center of excellence and which are actually catering to the medical value travel across the world. So this is what actually is happening. And so the India is, we provide the low cost. There is a lot of studies available, comparative study. And we are known to have the doctors, let us say in USA, 1/3 of the super specialty doctors are from Indian origin. So those doctors similarly in India are able to provide that kind of service. And on top of it, now we have got Ayurveda and yoga advantage. So that is also helping. And of course, the personalized service. So India today is among the top 5 destinations, which is providing the medical value travels. Over 7 billion revenue is coming from this particular thing. And overall and above, rich cultural heritage is the advantage. So to sum up, I would like to say that medical value travel is number 1, a big humanitarian initiative. Number 2, it helps setting up of the center of excellence in the country, because people will like to project that we are a country which is having top-of-the-line healthcare in our own country. Number 3, it creates associated infrastructure by way of smaller and middle size of the hospital to cater to the domestic population, because many times we feel medical value travel is for the foreigners and nothing is happening for our own people. No, actually it is both ways, it is going to help us. So overall, I think medical value travel is the one which one can venture and to help the people from the community and community from the nation, which unfortunately I will say do not have that kind of infrastructure. Thank you very much.
Thank you, Dr. Gyani. And well, our next speaker would be Dr. Sameh El-Saharty from World Bank in the USA. Dr. Sameh is the program leader at World Bank for GCC countries and Middle East. And he is going to talk about how investing in health is supporting growth.
Well, good morning, everyone. It's quite an honor and privilege and really to be here this morning to speak before this distinguished conference. And at the outset, I would like to thank the World Hospital Congress for inviting me, as well as I would like to recognize the presence of His Excellency, Dr. Ali Al-Hinai from the Ministry of Health for his presence. I really appreciate that. Well, I'm going to speak about the nexus between health and productivity and economic growth. And I think this is an important topic for us all to be cognizant of. So let me start by defining what is human capital. Human capital is the knowledge, skills, and health that a person accumulates over his or her lifetime to make him productive and able to contribute to the economy. And the story started by a publication that the World Bank has done last year called The Changing Wealth of Nations, that looked at how the wealth of nations accumulates over time. And the striking finding from this report that 2/3 of the wealth of nations come from human capital. And if you look at this chart, you see that human capital actually constitutes more than 70% in high-income countries who are not resource-rich. And even in resource-rich countries, it is 42%. And this has led the bank to have this report on human capital project, which was launched also last year. And the report has a human capital index that ranks all countries according to their human capital, the human capital that they have. And the index looks at the productivity of the future health of the future worker. How much a child born today will have in terms of full health and full education by the age of 18. And it has 3 ingredients. First, survival, because obviously a child who dies at the age of 5 will not grow up to be productive. And the second component is learning. The combination of how many years a child spends in school, as well as how much he or she learns. And the third component is about health. And there we have 2 ingredients, stunting and adult survival rate. And these 2 ingredients were chosen for a reason. First, why stunting? Because it has profound economic impact. And it starts during pregnancy, because unfavorable conditions in utero can actually have a loss of 5 to 9% of income. Similarly, the economic loss from stunting is about 7%. And reduction of stunting by just 10% can lead to 3.5% increase in productivity. This scan shows 2 brains of 2 children at 1,000 days. One of a brain of a stunted child, and you can see how the brain is not fully developed, and that affects, of course, his or her cognitive ability, education and skills, and therefore productivity over his or her lifetime, compared to one who is fully healthy. $1 invested in early childhood development can yield $6 to $17 in income over lifetime, as well as social benefits. And you can see the investment in early child compared to preschool programs, schooling, and job training and skills development. It is one of the most cost-effective interventions that we can have. Then, the adult survival. Why adult survival? Because improving adult survival by 10% can increase productivity by 6%. These numbers are important. Now, also, improving adult survival will also lead to improving life expectancy. And an increase of life expectancy by 10% is associated with an economic growth of 0.3 to 0.4% of GDP. Now, it's important to, and I'm sure you all know that adult survival is affected by non-communicable diseases because they are the cause of most of premature death. And NCDs affect human capital, adult survival and human capital through 2 pathways. One is the short term, which is adult survival, and the second is the long-term threat, which is related to morbidity. Why these 2 pathways are important? Because the first one, someone who dies prematurely before the age of 60, let's say at the age of 50, that means the economy is going to lose 10 years of lost productivity. However, even someone survives until the age of 75 years. He will not die prematurely, but for the 30, 40 years prior to that, he or she would have had probably a chronic condition, diabetes, cardiovascular diseases, and definitely it's going to affect the economy because this person will be less productive. But more importantly, it's also going to will pose burden on the health system because of the care that he or she will require. Now, these are some of the statistics regarding the economic impact of NCDs. Globally, it's going to cost $47 trillion by the year 2030. Latin America and Caribbean, the diabetes healthcare costs were estimated at about $65 billion annually. In sub-Saharan Africa, total health expenditures for cardiovascular diseases were estimated at $7 billion. In the OECD countries, the share of cost of NCDs range from 25 to 50% of total health expenditures. In India, a single stay for cancer in a public hospital represents 50% of GDP. And finally, in Tanzania, household costs for diabetes treatment represented about 25% of minimum wage. These are just examples of the cost of NCDs and how it affects the economy, both at the global level, national level, health system level, and individual level. Also, it is important to mention that about 100 million people are pushed under the poverty line annually because of healthcare costs. But we have the solutions. There are different packages that can reduce the burden of NCDs, of non-communicable diseases, not only through direct interventions, but also through reducing the metabolic and the behavioral risk factors like smoking, lack of physical activity, unhealthy food, hypertension, high blood glucose, and so on and so forth. And the WHO, Independent High-Level Commission on NCDs, came up with how much the different packages are going to reduce premature death. The Empower package to reduce tobacco use by 15%. The Shake to reduce salt intake by 6%. Vaccination against HBV, hepatitis B, and the HPV also can reduce the premature death by 5%. Hearts for heart attacks and stroke by 5%. Replace to eliminate trans fats from food, 2%, and you can see the list. So we have the solutions. And the World Bank, just last month, did a report looking at if we implement a package of NCD prevention and control, what will be the impact? So we did that in 10 countries that has almost 2/3 of the burden of NCDs globally. That includes China, India, Brazil, and I said 10 countries. And this is the result. It will lead to an increase in GDP annually by 0.5% and per capita by 0.7% over 5 years. So it's important to know the economic impacts as well as the return from investment. And why this is important? Because we have enough evidence today that spending on health is not an expenditure. If done effectively and efficiently, it is an investment in building human capital and therefore contributing to economic growth. Thank you very much.
Thank you, Dr. Sameh. Our next speaker is Dr. Fadi El-Jardali. Dr. Fadi is a professor of health policy and systems at American University of Beirut, and he is director of program Knowledge to Policy. And he is going to give us a talk about shifting from volume-based to value-based care, policy, and practice implementations. Thank you.
Good morning, everyone. Thank you so much for IHF, for the Dr. Eric, for the invitation. I'm happy actually to listen to all the speakers, and it's actually there's a nice link from Dr. Sameh's presentation. I think he provided very good evidence about the link between diseases or the economic burden of diseases. So my argument today here, the question is to what extent health systems are actually putting the right incentives to start working on prevention treatment rather than disease treatment. So this is really what I would like to discuss today. Much of my presentation is reflected from the experience I had by working and visiting many of the countries in the Arab region. So I'm reflecting a little bit from the experience in the context of the EMR. So we'll talk a little bit about value-based healthcare, what that means. I'm sure many of you know about that, but why it's a promising concept in a context, in a complex real-world health systems. I'll talk about the challenges and opportunities, and I'm going to reflect a little bit on policy and practice implication. I would like to start by this assumption. You might not maybe agree with me, but I would say health systems around the world are still far from achieving SDG 3, which is to ensure healthy lives and promote well-being for all ages. They remain predominantly sick care systems, disconnected from the broader upstream forces influencing health. A fundamental paradigm shift is needed if health systems are to be equipped to address complex and interconnected health and development challenges. And that's what really some of the area that I want to discuss in the presentation. I want to talk about value-based healthcare. I think this is a promising concept, particularly that is actually there is some good evidence that would allow to deliver accessible, high-quality care and making sure that we have the right incentives put in place to promote outcomes and impact, not only cost. It's important in light of increasing life expectancy, rise of chronic diseases, and increased healthcare spending across the world. And the question is really, it requires policymakers, stakeholders to reimagine their health system and reconfigure the right incentives and to focus especially on overall quality of patient outcome rather than the quantity and the cost of services. Now, I think the question here that how we can really incentivize providers, particularly physicians and others, in order to start thinking more about outcome and impact. So lots of benefits. I'm not going to go over them all, but there's a lot of good evidence about that. It's really have very good evidence for patients, for providers. Yesterday there was a nice presentation about hyper users in healthcare systems. How many people sometimes they come to emergency room for cases that shouldn't be treated in the emergency room. Providers, satisfaction, cost for payers, suppliers, and society. So there's a lot of benefits to that. Now, there's 4 main components need to be in place to promote that concept. First of all, we need to start measuring health outcomes, and I have to say we have a lot of challenges in many Eastern Mediterranean countries in trying to measure outcome in a valid and reliable way, report and compare outcomes, and compare outcomes for the purpose of improvement, not for the purpose of judgment. That's why some countries are experiencing now of public reporting, but it has to be done for the right reason, improve care delivery processes, and more importantly, reward high-value care. This is very important, how to create the incentives for that. Now, if you look at the application, a lot of interest. For example, if a surgeon will do a hip replacement surgery, there are some systems now where they actually, part of the payment for that physician is not only for the actual surgery. Part of it is a hybrid bundled model of payment where part of it, 10-20%, is related to the outcome, to the pain score of the patient, to the surgical site infection rate, to other type of indicators. So that's a good way to actually try to promote more value and outcome rather than pay only based on activity. So it's a concept that's being implemented in many countries. I'll talk a little bit about the context of Lebanon because my thought here that each country should start to experiment at its own pace, but start to scale up as they move forward. So we'll talk a little bit about that, but there are some good promising results as a result of that. I'm not going to talk about the model, but there's several models about pay for performance. There is a lot of systematic reviews not talk about the effectiveness of that if implemented in the right way, bundled payment, and population-based payment. So we need to see this more happening in our region. We're not seeing that much model, but we need to move into that direction. Now, certainly there's a lot of barriers. I'm not going to go over all of them, but certainly, are we providing the right incentives for people to invest in value and outcome and quality, or actually to do more activities? That's an important question. Time pressure. Sometimes we don't have the right measurements or the metrics. Lack of education and training. How much we actually change our curriculum in medical school, nurse school, and others to promote more value-based care. Fragmentation within the system. If I transfer a patient from primary care to hospital, if there is no integration across the system, that might be challenging. Diagnostic uncertainty, malpractice. There's a lot of some barriers to that. But I think it's very important to start really thinking about establishing the right policy context, measuring outcomes and cost, and try to promote more integration across healthcare system and moving more into an outcome-based payment approach. This is an important thing that we can really... Now, if in Lebanon, I'm going to go quickly to say that absolutely, population growth, we have a major burden of non-communicable diseases, aging population, more patients visiting facilities, we have significant gap in the system, and this means that we need to actually more work on quality. Now, Lebanon has an accreditation, but I would argue that accreditation is important, but not sufficient indicator to improve quality and safety. There are other measures that need to be put in place. We still have variation care provided to patients, depending where they go, public or private, no systematic way to improve and measure quality, lack of information to decision maker, few warning system to identify problem, avoidable error, and inefficient use of resources. So that's what we have. So the system in Lebanon is in transformation, but the reason why I'm bringing this example, because we're starting to actually experiment with performance-based contracting and pay for performance. So we were able to get funds from the Wellcome Trust, and we have done a study in collaboration with the Ministry of Health, and it's called performance-based contracting. And we're trying now to change the reimbursement model to start providing much more incentives to providers, both healthcare facilities and health providers, clinicians, in order to start promoting more values. We have a new scoring model. So we're trying to experiment. We're not saying that we have done it all. What I'm trying to say that each country can start at its own pace in order to promote more this type of value. The problem that we still have, limited capacity to monitor service delivery. Accreditation also is insufficient, as I told you. We have some cases related to the payment, etc. So there are some of the challenges that we have in the system. Now we're starting to promote more a hospital performance report card. We're trying to provide this to hospital, and this is not, and we're saying hospital, this is measurement for improvement, not measurement for judgment. This is very important. Otherwise, the private sector will not buy in. Don't forget that we're doing this both for public and private sector, particularly that in Lebanon, most of the services are funded by or provided by the private sector. So what I'm saying is that we are in transformation. We're trying to actually try to see what changes need to be done at the governance level, service delivery level, and financing level in order to improve outcome, safety, and have better investment in human resources, better financial utilization, etc. So it's the question here, are we aligning incentives or we have misalignment of incentives? This is an important thing when it comes to promoting value-based healthcare. So that's why we need to move towards people-centered health system. I was happy to hear some of the presentation yesterday is really focusing on that, particularly that healthcare accounts really for around 20% of personal health and well-being. Now, I want you to look at that. If we look at the influencers of health, and how much we are really spending, you will see that this is a bit, it's a bit challenging. So we're actually, if you look at this, the social influence of health, social economic factors, health behavior, physical environment, etc., genetics, and only healthcare 20%. But look how much we are really spending on this. So healthcare spending is almost entirely focused on sick care, not on what makes people well. And that's a fundamental shift of thinking that we need to actually promote more in health systems. So are we getting the right incentives? That's why when we talk about health system, we're talking really about a system beyond only health or Ministry of Health. So this is important that we need to focus on. So what I'm going to end up by saying, what can leadership do? Right investment in existing resources, reconfigure the ecosystem, redirecting of resources to ensure efficient services and reduce waste, invest in human capital and availability of healthcare data, which is really important. Reconsider model of care. We still actually treat people based on body part, but we don't really providing a holistic type of care based on a multidisciplinary and interdisciplinary teamwork. Development of quality measures and regular monitoring. Need to involve staff and clinical leaders to start to see how we can streamline our models of care. Leverage and harness the power of artificial intelligence. This is very important. I was 2 weeks ago in the World Health Summit. I attended part of it. Some of my colleagues were here in the World Health Summit. There was a lot of focus on artificial intelligence and what that means to health systems. Now we know in the population what type of people they will get sick when they are 40 or 45. Why don't we start working on prevention treatment now rather than treating them later on and spending more money on them when they get sick? So it's a fundamental shift of how we look at systems. That's why there is a policy implication to that. The health system should be still organized around specialties. We need to actually move more into value-based care. This is very important. We need to actually create robust quality metrics. We need to invest in the infrastructure of information exchange. We still have in our region, we don't have a lot of publicly accessible data sets for people to look at. We still don't have valid, reliable indicators that we can measure and benchmark to. These are important things in order to promote it. So exchange health information, data, improve meaningful use of health information technologies. All these are really important in terms of this. I want to end up by saying that there is a big opportunity for the Eastern Mediterranean region, because for the first time, the region, we are hosting the Global Health System Research Symposium, which is the biggest health system symposium in the world. And this is my center, the K2P Center at the American University Beirut, is co-hosting this in collaboration with Dubai School of Government. And this will be in November 2020. But the reason why I'm bringing this, because this is the theme for next year's symposium, reimagining health systems for better health and social justice. So it's very important actually to start really bringing all the stakeholders in health and outside health to start thinking how we can really look at health system. We're focusing on political forces, how we engage with political leaders, with policymakers, how we can engage with social, economic, and environmental forces, and how we leverage in technology, data, and social innovation. So hopefully we'll have opportunity as well to be at this symposium and have also opportunity to speak at that symposium. Thank you so much.
Thank you, Dr. Fadi. Well, so we heard about hospitals and their role in community development. We heard about the role of medical tourism in increasing quality as well increasing income for countries. We also heard about how we can shift from volume-based to value-based, and also how investment in healthcare would accelerate growth. So quite inspiring talks, quite inspiring presentations. Maybe I will start with the first question to Dr. Melinda Estes. And I was taken by the slide where you showed the photo of the house of Mark Twain. And that I recalled his famous statement when he said, "I have never let my schooling to interfere with my education. I have never let schooling to interfere with my education." And Mark Twain was referring to the importance of differentiating between schooling and education, because schooling is only the schooling process, while education is changing behavior. So he was emphasizing on the need for changing behavior rather than exams, homeworks, grades, etc. A wisdom probably appears to be quite needed in healthcare. You talked about being kind, being compassionate, being responsive to suffering of others and considering it suffering of yourself, and the importance of reconnect to our human fellows. So you call to be nice, while some people call to be smart. So how can we, my question is, how will you be able to inspire your people at St. Luke to be nice and smart at the same time?
Thank you. Is the mics on? Yeah, perfect. Thank you very much. I mean, that is a very interesting question, and I appreciate the connection. You know, I think we globally, and certainly we in the United States, have a healthcare system that is full of very smart people. We have tremendous specialization and subspecialization and sub-subspecialization. We have an enormous amount of technology, and we apply that technology to the care of our patients. But as was referenced here, the move from volume to value requires you to look at truly what do your patients need, where do they need it to be provided, and having us change our mindset from our first default is the hospital emergency room or the procedure or the high technology that we have. We at St. Luke's have a full array of technology. We are one of the leaders in the United States in cardiovascular care. And what we have worked on is trying to say to our St. Luke's family, which is 12,000 strong, that it is not as important to the technology is there, the expertise is there, but how do we deliver that care? How do we provide to our patients kindness to our patients, kindness to each other? And I think it has resonated with our caregivers. We did an employee engagement survey. We do one every year, and we had 3 kindness questions on our employee engagement survey. And it is a 6-point scale. And the question of being kind to patients and kind to each other scored 5.84. So it was the highest score on all of the things. And so we talk about kindness because we monitor outcome, we measure quality, we look at throughput. We have beginning to change our delivery of care, managing chronic disease close to where the patients are. But at the end of the day, it is about our education. It is about the education of our patients. And so we were not surprised, but quite pleased to recognize that most of us who work in healthcare are altruistic at heart. And at the end of the day, kindness is a part of measuring that. So thank you for the question.
Thank you. Well, this will take me to the following question, which was raised by one of the audience, so and which will be directed to Dr. Sameh. Well, being nice sometimes is perceived as vulnerability to lose money. Because if you would like to be nice, you need to spend money and you do not expect a revenue. So how can we sustain doing this? How can we continue to be nice and still maintain financial viability of the whole system, especially when it comes to who would pay for preventable non-communicable diseases, and what should we tax, and what incentives will work while balancing equity? So that is the question.
Okay, let me just start by, pointing out to what Dr. Fadi has mentioned in terms of the importance of the socio-economic factors, the social determinants of health. 40% of health outcomes are affected by income, education, employment, and so on and so forth. About 30% comes from behavioral, smoking, lack of physical activity and unhealthy diet, and 10% from the physical environment, whether air quality or built environment. So that's important. Why? Because we need to engage other sectors in our health policy dialogue. They play a key role, and it has to be a win-win. So the question about who should pay for preventable NCDs, I think the focus should be on the behavioral, environmental risk factors, and what contribute to these risk factors in terms of the sectors. Transport, for example. We end up in our emergency rooms with, post-crash injuries, but working with transport ministry and municipalities, we can improve road safety, and that will reduce the burden on emergencies. The same with Ministry of Finance, in terms of tobacco taxation. Ministry of Industry in terms of food imports and labeling of food, and so on and so forth. So the first aspect of it is to focus on the role of other sectors that they can play in reducing the burden of NCDs by focusing on the risk factors. The other part of it, which many health systems, many health sectors now, and policymakers are becoming increasingly aware of and working on, is the importance of prevention, not just in terms of the healthcare system by screening, for example, for hypertension and diabetes, but even working upstream. I know, for example, that many health insurance companies in the US have applications by which the patients, when they buy healthy food, when they exercise, when they do their medical checkups, they get credits, actual money, because health insurance companies recognize that, by encouraging this kind of behavior, this will reduce the health insurance cost down the road.
So what incentives will work while balancing equity?
The question is really about the NCDs. Now, I have to say, so there are different measures and different policy instrument that has been used by different countries when it comes to taxation and health, and I think that we have some promising evidence related to the impact of taxation. So this is more from a revenue generation. But I think the importance is really finding the right incentives and actually doing it for the right reason, and alignment of incentive. What that means. So the question is, for example, for the medical workforce, for physicians, what are the incentives that they have now in place in terms of how we are paying them in order to actually invest more efforts in outcomes and value? That's the question. I think it's important. Are we really are we rewarding good outcomes as the result of medical intervention? In my country and many countries in the region, we're actually rewarding activity. So that's an important. So finding the right incentive and implementing it is very important. Now, if you look at it, if you look at Europe, North America, different countries, there is a different hybrid model of doing the incentive. And I'm from the people that said that we shouldn't really start by harsh incentives. So we need to start really, at a softer pace. What that means, for example, if I recall, I think either Sweden or Sweden, they have now a hybrid model. I think it is Sweden or other countries in Europe, where they have actually a hybrid payment model. It's around 10-20% dedicated to value out of the whole payment. So the question is really in terms of financial arrangement, what needs to be changed at the level of how we are financing healthcare in order to actually integrate more in terms of how we are delivering the services. So now we're still, how to promote the concept or create incentives for nurses, physicians, dietitians, social workers, all together work to provide a coordinated, integrated treatment plan for a patient with chronic diseases. We still don't have this type of incentive. We have incentives, in fact, now, or perverse incentives, for physicians not to refer their patient to other specialty, because they are worried that they will actually lose their patient. This means losing the income that will come from that patient. So looking at the incentives, there's no one size fits all. Each country should actually assess the current health system arrangement that they have, how they finance healthcare services, how they deliver, how they regulate, and they actually start with actually experimenting with certain incentives that can work in their system. But lots of evidence about what incentives could work and what incentives could create another perverse incentives.
Well, thank you. We have a question about the timeline of transformation of healthcare. Maybe I would rephrase it a bit. Yeah. Maybe all countries on this Earth planet are interested in healthcare reform. And it appears they behave a bit different from each other. The success rate is different from each other. If you take Singapore, Hong Kong, Southeast Asia versus Cuba, and Latin America versus United States versus Scandinavian countries, Sweden and Norway and others. But it seems they have different ways of doing it. It seems they have different methodologies. But what about the time factor? How much time it would require for a health transformation to be achieved? And yes, we talk about great ideas. We talk about equity, equality, being efficient, being responsive, being passionate, compassionate, etc. But how much time it will take? People will not wait for 50 years for this to happen. And based on your experience, and probably other panelists can contribute, what would be a realistic time frame for a true health reform to happen? And if we focus on GCC countries and Middle East, what could be a time frame?
I'm happy to, I think this is a tricky question, I have to say. When it comes to timeline, there is no actually magic bullet about timeline. Let's start by that. But I think what is really important with this question is that not only what is the projected timeline, is that the question that each country should ask, do we have a common vision for how we would like our health system to look like 5 years from now, 10 years from now, 20 years from now? I think having a plan with a timeline without more an agreement on a common vision, this is very challenging because the plan will fail. Why I'm saying consolidated vision, many of our countries in the region, talk about Lebanon and other countries, but not all of them, there is a predominance of private sector. There's private sector, civil society groups, faith-based organization, public sector. Many public and private sector are involved in providing health. The question, do we have a dialogue among all the stakeholders, what we would like to actually achieve in the next 5-10 years? That's first. Second, what I would say, my worry is that if you say 5 years or 10 years or 7 years, there's no right number. But the question is, if there is no realistic plan that is really implementable and monitored over time with the right metrics, meaning, or the right engagement, meaning some of the plans could fail. We have seen a lot of examples from the region, not all the region. I'm actually astonished and impressed by the work that Oman Ministry of Health has been done. They have, I think, a strategic plan for 2050, which is really quite interesting how they are thinking about the vision of the health system. But we don't find this a lot in many countries in the region. Second, we have a lot of examples in the region where lots of plan, lots of nice timeline, but also failure in the implementation. So my advice, yes, timeline matters, but start at smaller scale and then scale up. In Lebanon, we've done that from around now. We're entering the 5th years of changing the mindset of private hospitals and physicians and clinicians, that we start now to think about quality, safety, and outcome and metrics. 5 years it took us. Now we are implementing a hybrid model. Now, you'll tell me after a few years, we'll start actually seeing the impact. So it's not going to be a magic bullet. But I think we are on the right track, hopefully.
Good.
If I may just add quickly, health reform is actually a journey. It is not something that, you're going to start and going to end. It's a continuous process. And we have to learn, because it's a very complex journey. The second point is that it's no longer a luxury. The healthcare cost increase is higher than GDP growth. So there is a lot of pressure on governments to try to rationalize healthcare and try to reform the health system. And the third point is that we need to focus on patient-centered, approach using the technology. Why this is important? Because this can actually empower patients, reduce cost, both on the health system as well as on the health service delivery system.
Sure. I am sure there are many questions. I will just save the last minute for Dr. Gyani. And it is related to one of the questions, which was related to the right terminology and right definition of care. Should it be disease-based or people-based? Something we heard from you, Dr. Gyani, you mentioned people like to travel. They travel and they will continue to travel. And they travel for leisure. And they travel to feel happy. And why don't we capitalize on this? So people seek for happiness. Let us capitalize on their seeking of happiness to improve their health. So to me, this is an interesting approach, because now we take things from perspective of people rather than our perspective. So is this generally a good strategy? And how would this inspire us to improve things?
Yeah, of course, if we can really combine the medical travel with the pleasure, with the tourism, that of course will be the ideal. And that is where, if you see that top 5 destinations which are offering medical value travel, Actually, I also have inbuilt component of the pure tourism. So that, the people, but I will still maintain that primarily people go there only after assessing that where they are going, the level of quality, level of healthcare has the definite quality. And that is where the international accreditation also is playing its role. So, but I agree with you that if we can combine the two, the people will be happy to go to the place, also get their healthcare needs addressed, and at the day of it also have the bit of pleasure and enjoyment. So that is where.
Thank you, Dr. Gyani. I'm sure there are many, many other interesting questions, but we came to the time of closing this session. Well, thank you all. Thank you.